All right. I would like to see the slides, Dr. Jumana, because I can't see any slides. No. So while you're doing the slide setup, I'm going to ask few questions to everybody. So I know you guys went over some stuff. Does anybody have any questions? Yeah, I can see the slides now, Doc. Yeah. So does anybody have any questions? I can go over that. All right. So I am going to go ahead and present then. So wanted to talk to you guys about composites, amalgams, glass ionomers, SDF, space maintainers. We have a lot of stuff to cover, but I'm going to be quick and fast. So composites are almost similar as permanent teeth. There is not much difference except that, what happened to the slides? Okay. So, except that the material, the restorative material is less retentive on the permanent teeth. So, just because the size of the teeth is small, it's close to the pulp, all those reasons cause the restorative material to be less retentive. So, I have a question in your slides where I'm asking you primary teeth have less retention of restorative material due to, so read the answers carefully. Like in one of the question I've said enamel is thin and so more surface area for bonding. So remember the surface area is decreased because of bonding. Dr. Jumana, can you go to the next slide? Yeah, thank you. So, obviously the children behavior is one of the main thing when we are doing pedo restorations. So, you got to be vigilant about how the child is behaving and what kind of filling we can do on them. Next slide. Um, so, just when you are reading my questions, there are little bit of tricky things I have written. Like I might have said more surface area instead of less surface area. So just watch on those things. Then there is low bond strength in primary teeth because of these following reasons. You guys have to just memorize these things. So just that the dentine is less mineralized and the enamel is prismless. So there's no prism. So acid etching is difficult to do on the enamel. So remember the bonding is difficult. Next slide, Dr. Jumana. So now, when do we do composite fillings on, pedo patients? Just remember when it's small cavities, when it's cooperative patient, when it's easy for you to do it, then you do composite fillings. Composite fillings are very technique sensitive. You don't need any moisture, no saliva, no blood. So you want to do it like class 1 cavities, class 2, which are small cavities. Next slide, Dr. Jumana. But when it's bigger cavities, multiple surfaces, the patient has lots of cavities all around his mouth, then in those cases, you don't do composite. So in high risk patients, it's good idea to do glass ionomers. And why is it a good idea to do glass ionomers? Because you can do multiple fillings at the same time. You can have moisture, blood, subgingival cavities, and it releases fluoride. So do multiple restorations with glass ionomer. Even in less cooperative patient, it works pretty good. So, you can use glass ionomers in big restorations, and then on top of it, you can put a stainless steel crown or something like that. So, next slide, Dr. Jumana. So when you do a class 3 composite, you remember in permanent teeth, we only drill where the cavity is. But in this one, we drill more than the caries. We make a little dovetail because we want to increase the surface area for bonding. Next slide. So you just basically, you can go through the facial. You just want to make sure there is good isolation, good bonding. Next slide. Everything is, you put the mylar strip, you put the wedge, you bulk fill it, and you want to be fast. So in this case, they have used a cord because it was subgingival, the caries. So in subgingival they have done composite, but this would have been a good candidate also for glass ionomers because big cavities, but see how nice they are looking. Composite is going to look much better than glass ionomers. So that's one thing, And I don't know if you guys have seen these matrix rings, the de novo matrix rings. You guys just have to play with them and see how you like them. So now I'm going to switch to amalgams. I also wanted to talk a little bit about pulpatomies. So, when there is deep decay and you know that the pulp is going to be exposed or it's very close to the pulp, you're going to plan to do pulpatomy. So I want to know how many of you know the difference between pulpatomy and pulpectomy. Just raise your hand if you know the difference. Okay, so I'm going to go over that. So pulpatomy you do when you go inside the pulp of the tooth, and when you drill, you want to go inside and remove all the pulp horns, and then when you see bleeding from the pulp, you proceed with pulpatomy. But if there is no bleeding, that means the tooth is dead. If the tooth is dead, you cannot do pulpatomy in that case. You have to switch to pulpectomy. Pulpectomy is root canal treatment. Okay, so in that case, where you have to do root canal, you have to see if there is an abscess on the tooth. And then depending upon that situation, you do pulpectomy. So I wanted to ask you guys, do you think doing a root canal on a baby teeth is a good idea or not? Does anybody want to answer? Okay, it's not a great idea to do root canals on baby teeth because the baby teeth have thin roots, flaring roots, very hard to determine if the roots have started to, because of exfoliation, the resorption has started. So it's not a easy thing to do, and they are not that successful. So that's one question you guys need to answer in the test. So now you just place the matrix band, the wedge. Go ahead, Dr. Jumana, and then proceed with your composite fillings like we have taught you guys. So I think that's it, doctor, and then finishing burrs. Let's go switch to amalgams. So amalgams in the primary teeth are almost similar to permanent teeth. The next slide. The only difference is that the primary teeth have small size. And so when you are drilling for the amalgam, for permanent teeth, you have to drill 1.5 millimeter. But Dr. Jumana, go down further, like from, yeah. So right here, yeah. So, but for the for the primary teeth, you go less than 1.5 millimeter in primary teeth. So be careful because the pulp is very close on the tooth surface. So you have to be careful. And there is less occlusal anatomy. Next slide. So you always use, everything is small diameter, condenser, small burnisher, everything to the scale gets smaller. You use the matrix band. You can use these matrix bands. Go ahead, Dr. Jumana, just keep going. So, and then you condense. With a condenser, you want to condense forcefully, and then you don't want any voids, and then contour it. You don't want to define too much anatomy, just the main grooves need to be defined. So we'll go over that. Now, next, I want to go over space maintainers with you. So let's go over space maintainers. So when do we need space maintainers? Space maintainers we need in case when the patient comes to us and he or she has lost a tooth earlier than we would like them to lose. So if you have noticed, I have attached a paper. So if suppose a patient comes to you and his second molar is hurting, all we need to talk to the patient when he is in our office. So if a patient has a lot of cavities, you want to discuss all the things like the sugar, the sticky food, brushing, flossing, fluoride, if he's using any fluoride. If not, there is a chart, I can find it for you guys, that in each zip code, how much fluoride is in water. So if they don't have any fluoride, you want to give them fluoride mouthwash. So I normally prescribe Act mouthwash. I don't prescribe fluoride tablets because I feel like then they are injecting fluoride in their system. So I don't like that. It's also critical that you ask them if the parents or the sibling have cavities, because a lot of time cavities are genetic. Like your genes kind of determine when people will have cavities. So remember, this is important that you check with the parents why this thing is happening, and that we need to change certain things for the patient. So I'm going to ask you guys with this in front of you guys, I'm going to just ask you some clinical questions. So if a patient comes to me, he is 7 years old, and his upper second molar has a big cavity, and he's having pain in the tooth. And we try to save the tooth, and we're not able to save the tooth. We extract the second molar. Are you going to give a space maintainer in this space for the second molar?
No.
No? No or yes? I can't hear you.
It's the second molar.
It's the second molar. Are we going to give a space maintainer or no?
Yes, distal shoes.
Okay, so yes. But remember, the patient is 7-year-old, and so the permanent first molar has erupted. Okay? So the distal shoe you give in case, you have a very good point. When do you do a distal shoe space maintainer? In this case, you're going to do a band and loop because you have the first permanent molar here. So you put the band on the first permanent molar and you give a band and a loop space maintainer. Distal shoe you give when the kid is below 6 years of age, when the first permanent molar has not erupted. So if the second molar, we could not save it and the patient was 5 years old, then you give a distal shoe space maintainer, because now you want to kind of direct the first permanent molar eruption. So in that case, you give the distal shoe space maintainer. Did you get my point? When do you do a distal shoe versus a band and loop? Yeah? Okay. All right. Good. So now let's go to another scenario. In the lower tooth, the first molar has a big cavity and the patient is 9 years old. And the tooth is little mobile. And we decide to pull out the tooth. Would you go ahead and do a space maintainer in this case? The lower first molar. 9-year-old patient, The tooth is little loose, and it has a big cavity in it. Would you want to do a space maintainer or not? No, right? Because the permanent tooth is going to come pretty soon, and this tooth was loose. So it is kind of an indication that the permanent tooth is right there. So you don't do a space maintainer there. All right. Now let's do another scenario where in the lower second molar, there is a big cavity. The patient is 5.5 years of age. Okay. In this case, the patient comes to you and you kind of go through your diagnosis and everything. What do you want to do pulpotomy? If you are not able to do pulpotomy in this case because there is no bleeding from the pulp, are you going to try to do a pulpectomy, a root canal on this second molar, the lower second molar? The patient is 5.5 years of age. Are you going to try to do a root canal or not on this second molar? Okay, yes, because the first permanent molar is going to erupt around 6 years of age. So we want to buy some time, that we want to keep the second molar in the patient's mouth. So just for 6 months to an year, if we can buy some time and we don't have to do a distal shoe space maintainer, we go ahead and try to do a pulpectomy. It's a difficult one. A lot of times it might not be successful, but in that case, we try to do a root canal, a pulpectomy in this case. All right? Okay, and now I'm going to ask you guys a question. A patient comes to me, his first upper molar needs a pulpotomy. When I go in the tooth, there is bleeding. Can I go ahead and do pulpotomy or not? There is bleeding of the pulp when I reach. Should I do pulpotomy? Remember, if there is bleeding, yes, you do pulpotomy. If there is no bleeding, then the tooth is dead, you don't do pulpotomy. Okay, now a patient comes to me, he has lots of cavities. He has poor oral hygiene. He has lots of cavities which are subgingival, and he's not very cooperative. What kind of filling should I do for him? Should I do a composite, amalgam, or glass ionomers? Can anybody answer for me?
Glass ionomer?
Yes, very good. You should do a glass ionomer. Good. Now this one is a bit tricky one. I don't know if you guys know it, but there. When do you do a bilateral fixed space maintainer on the? There's a bilateral space maintainer on the upper teeth, which we do in certain cases when the patient has lost, suppose, the first molars, upper first primary molars, and the canines. Then you do an appliance which is called as Nance button appliance. Okay, a lot of times clinically we don't do it. Just I wanted you guys to know about it. Okay. Do you guys have any questions? A patient comes to me. First molar has a small cavity. Patient is very cooperative. The mom wants white filling. What kind of filling am I going to do? Composite, amalgam, or glass ionomer?
Composite.
Good. Okay, a patient comes to me. Mom says, I don't care what filling you do. It's lower second molar. It's a small cavity. What kind of filling are you going to do? Amalgam, composite, glass ionomer?
I guess it's composite.
You can do composite, but the mom doesn't care about it. You can do an amalgam filling. It's going to fall. It's going to shed. And it's simpler sometimes to do it.
Why
So,
just apply SDF?
no, but the patient is cooperative
Oh, okay.
and it's a second molar. I mean, SDF, you want to use SDF. I think, Samantha, you brought up a very good point that SDF you want to use in situation when the patient is bit uncooperative. If you can do fillings on the patient, like you can do a glass ionomer, you can do composite amalgams, you can drill out the decay, you want to do the fillings for the patient, because then they don't have to come multiple times to visit you also. And just for one tooth, I mean, it wouldn't make sense. But yes, if the patient is uncooperative and the mom can take them to the specialist, because when they take them to the specialist, even they have insurance, they charge the patient for giving them nitrous and GA. And a lot of parents can't afford that. So then in that case, you give them SDF. You apply SDF to their teeth. Any questions you guys have? Oh, and then I wanted to say in nursing bottle caries, one of the significant thing you will see is that the decay starts right at the gum line of the patient. And that is the reason, and it's like a white dull line that the parents can't notice it in the beginning. And then slowly they go ahead. And then sometimes patients come and they will ask you, okay, I'm pregnant. When can I start bringing my child or my baby for a checkup to your office? So when their first tooth erupts, that's when they need to start bringing their baby to the office, which is around 6 months to 8 months of age. Because we want the baby to start getting familiar with our office, with us, and then we start teaching them how to clean their baby teeth. You might have seen, first you have to tell them that they have to use like a cotton cloth to wipe the teeth and the gums. There is a special finger brush. Have you guys seen that finger brush? And then you tell them that they can use that finger brush. And no fluoride toothpaste till the kid can spit. So that is very, very important for you to know as a clinician, that they cannot use fluoride toothpaste. So there is this other toothpaste, no fluoride toothpaste, which comes. They can buy that to use on the kid. Dr. Jumana, do you want me to cover anything else? I think I covered everything. It is tricky to identify. Sometimes it's difficult to identify whether it's a permanent first molar or whether it's tooth number A. So what you do in that situation, what I used to do is I kind of used to look at the teeth, like, you know where the central incisor is, right? So from the central incisor, you see if there is three teeth in the very back, then it's the first permanent molar. Because the problem is the first permanent molar and tooth number A look very identical sometimes. And so it's hard to make out the tooth. So, you have to just keep looking at the teeth again and again, different scenarios, and then you will be able to identify situations like that. So you have to keep practicing that. Maybe I'm going to see if I can find some questions like that to put it out for you guys sometime.
Can we do both? Yeah, can we like do it by ourselves and then go over it with you, or you can ask questions and then we can let you. Bye.
Bye, guys. Thanks
Bye,
for your job.